That was a tour de force of bladder and kidney cancers in 20 minutes. Great job, Charles. All right, so my job was to talk a little bit about what's coming in prostate cancer, and I thought we'd really highlight some of the precision oncology and targeted treatments that we have in prostate cancer. My disclosures, the ones in blue, have approved therapies that we'll talk about. Those of us who treat prostate cancer are very well familiar with this disease continuum from localized to non-metastatic castration-resistant prostate cancer and then to metastatic disease. Many therapies have evolved in the last decade or so. For purposes of this talk, we'll talk a lot about the homologous recombination defects and PARP inhibitors in that space, particularly the combinations, and then we'll spend some time on PSMA lutetium therapy. There's a multitude of genetic drivers in prostate cancer. Those of us who are sending those circulating tumor DNA tests, those are, or the tissue-based NGS sequencing are seeing most of these mutations and alterations. Some of them are slice variants of androgen receptor come up in our diagnostic reports. Some of these are germline, so in the homologous recombination defects, BRCA2 are the most common, ATM, CHEK2, and BRCA1 follow in this prostate cancer space. But many of these are somatic, like the P10, TP53, RB1 loss. And so in terms of thinking about these mutations, many of them can be indolent disease, so they're still androgen receptor driven. HOXB13, for example, is a germline variant that predisposes to prostate cancer, but most of these prostate cancers are indolent. As you get into sort of intermediate genetic alterations and then into aggressive disease, I find personally the P53 and RB1 loss are quite hard to treat. These are very aggressive disease, and often we only are looking at chemotherapy for those folks. BRCA2, BRCA1 also in my clinic present with castration resistance early on. They're not androgen receptor dependent. And then we'll spend a little bit of time about CDK12, show you some of the data there as well. So targetable alterations in prostate cancer, well, certainly the androgen receptor is targetable. Our treatments in prostate cancer really hedge on androgen deprivation and AR inhibitors, chemotherapy for AR variants, and then homologous recombination defects. So BRCA1, 2, and ATM are the most common, and we have PARP inhibitors now. We'll spend some time delving deep in the combination trials. MSI high and TMB high, pembrolizumab is approved across the board for these tumor agnostic but high microsatellite insufficiency patients. And then also CDK12. CDK12 is interesting. We'll spend a slide on that. Our preference is to give PARP inhibitors over immunotherapy. P10 loss, the AKT inhibitors are coming, and also the bromodomain inhibitors are in trials now. Approximately 20% of folks, so when I test these folks in my clinic, I kind of quote to them, probably about 20%, so 1 in 5, will have some homologous recombination repair defect. And so when you look across BRCA2, CDK12, ATM, in this real-world population is coming up most frequently, but about 20% of folks will have something that we could target and think about PARP inhibitors. There is now level 1 evidence from 3 phase 3 trials for patients with metastatic castration-resistant prostate cancer, naive to AR-targeted therapy. You may have had some of these trials open. PROPEL was olaparib, abiraterone, Magnitude, niraparib, abiraterone, and TALAPRO-2 with talazoparib and enzalutamide. All 3 are approved indications now and combinations that we can use. So how do these 3 trials differ in the patient populations that were enrolled? PROPEL was a unselected patient population, all comers, randomized to olaparib and abiraterone compared to abiraterone with placebo. Magnitude was the clearest prospective subsetting of these patients. So all the patients with homologous recombination defects were put into cohort 1. Everybody negative for homologous recombination defects were put into cohort 2. So they're very separate populations within that sort of all-encompassing PROPEL population. And then TALAPRO-2, the first cohort was agnostic to homologous recombination status, and then that cohort 2 was then enriched for homologous recombination defects, and that expansion for really enriching the population that's likely to respond for talazoparib and enzalutamide versus enzalutamide with placebo. So radiographic progression-free survival was positive in unselected patient population. So you see that in PROPEL on the left and TALAPRO-2 on the right. And that benefit is really driven by the homologous recombination altered groups. And this was a big debate at ODAC a couple years ago now for PROPEL, because their trial was designed for the intention to treat population, but their label ultimately was for the homologous recombination defect BRCA1, 2, and ATM patient populations. Magnitude 2 had that very clean HRR negative patient population. As you see, radiographic progression-free survival was not seeing a difference between niraparib and abiraterone versus abiraterone with placebo. And that benefit in particular is driven by these BRCA1 and 2 altered subgroups. So you see that very clearly for both PROPEL on the left and Magnitude on the right. And that is what ultimately drove these indications in the selected patient populations. Overall survival is not quite there across all of these combination trials, and overall survival as an endpoint may not be met if these patients in the control cohorts ultimately received some PARP inhibition after they came off of the trial. So I was a doubter on these combinations until a BRCA-OA study really changed my mind. BRCA-OA was an investigator-led trial, smaller cohort, led by Maha Hussein and her colleagues first at Michigan and then at Northwestern, but multi-site trial, screened 161 patients and treated 61 of them with BRCA1, 2, or ATM population alterations, and treated with either single-agent abiraterone, single-agent olaparib, or the combination of olaparib and abiraterone. And then the patients on monotherapies were allowed to cross over. And what we saw with radiographic progression-free survival was that the combination certainly had benefit over each of the single agents, but also for PFS2 for the monotherapies used in sequence, each of those, abiraterone followed by olaparib or olaparib followed by abiraterone, had a PFS2 time of about 16 months. So that's randomization to second progression, versus the combination for abiraterone and olaparib had that progression-free survival of about 39 months. So that combination really does help compared to sequencing the monotherapies. And so why is that? So if we think about clonal solid tumor evolution and think about how we use our treatments in sequence, if we are using that PARP inhibitor on its own, that we're allowing those AR-driven cells to grow and that resistant population to grow, if we're using these combinations together, then maybe we're targeting both the PARP-sensitive cells as well as the AR therapy-sensitive cells, and maybe that clonal population that's resistant to both doesn't grow or it takes a longer time to grow, so that PFS is prolonged. Want to spend a slide on MSI-high prostate cancer. This is a cohort of folks that our Fred Hutch colleagues assembled a couple years ago now. You see PSA responses on abiraterone and enzalutamide are not actually that great, but if you treat these folks with pembrolizumab, many of them can have good PSA drops, and I'll show you an anecdote later on in this talk. CDK12 is a really interesting one. So CDK12 works within the RNA polymerase to help transcribe some of the homologous recombination genes. And so it actually results in higher tumor neoantigen presentation. And so for a while, we thought there would be good responses to immunotherapies. In the past year, Dr. Nguyen, who just spoke, published a multi-center trial called the IMPACT trial, and they selected patients with castration-resistant prostate cancer with CDK12 mutations and randomized them to cohort A of ipilimumab, nivolumab, or cohort C with nivolumab alone. And you're seeing here the spider plot of PSA responses. Only a couple of patients, 2 patients in cohort A had PSA 50 declines, so declines of PSA 50% or more. And so our current treatments for CDK12 is to think about PARP inhibition, particularly talazoparib and enzalutamide. It is part of that panel that's approved for talazoparib and enzalutamide, less so to think about immunotherapy for these folks. PTEN loss is also really interesting. PTEN loss is an aggressive form of prostate cancer in many of our clinics. There was a press release last year of Capitello 281, phase 3 trial of metastatic hormone-sensitive prostate cancer with PTEN loss. This was a positive PFS, and they're undergoing further follow-up for overall survival. We have not seen the full data yet, so more to come and to look forward to there. It is colored by the prior ipatasertib trials, which were negative, so we have more to see for PTEN loss prostate cancer. So with all of these, I think molecular testing certainly is important. We need to find those patients likely to benefit. I tend to use the commercial ctDNA platforms, but also tissue is gold standard. So if you have a lot of negative tests or low tumor burden, sometimes we can't see the ctDNA very well. And if something's biopsiable, getting that tissue and doing NGS testing on the tissue is gold standard. All right, we'll spend the latter half of this on PSMA lutetium, which many of you probably are integrating into your practices for refractory prostate cancer. PSMA-targeted lutetium is a beta emitter, a radioligand that's targeted to prostate-specific membrane antigen, PSMA, and it's able to target both soft tissue and bony lesions, which is really positive in our refractory patient populations. The therapy trial was done in Australia. It was the first randomized trial for lutetium PSMA, and they selected folks really carefully for PSMA expression. So SUV max is over 20 at any site, no FDG positive disease, and treated them with either PSMA lutetium or cabazitaxel. So it was randomized against chemotherapy in that refractory patient population. Here are the baseline patient populations. Many of these folks had either abiraterone or enzalutamide or both, and coming into pretty refractory disease. Therapy efficacy, we saw higher objective responses for patients treated with PSMA lutetium, about 67%, and progression-free survival was improved for those patients treated with lutetium versus cabazitaxel. There was no difference in overall survival, and this phase 2 trial was not powered for overall survival, but there were crossover rates in particular in Australia. They had good access to lutetium, so those patients who received cabazitaxel, many of them went on to receiving lutetium. I am really interested in that screen fail population. So they did not treat that segment of FDG positive, PSMA negative patient population on therapy. And what you're seeing here is that they followed those patients still and showed that that screen fail population had poor prognosis. So this is mostly the anaplastic neuroendocrine prostate cancer that we see that's really difficult to treat in our patient populations. And certainly this patient population is a group of patients that we need more therapies for. The last thing we'll talk about PSMA PET and what they were really careful to show in therapy was which patients were predictive of response. So PSMAs with SUV means on their PSMA PETs of 10 or more were more likely to have a response from the lutetium PSMA than patients who had SUV means less than 10. So we're very careful with our nuclear medicine folks and to really drill down on SUV means as they're reading out these reports and helps us set some expectations for folks as they're coming in and thinking about lutetium, who's more likely to respond versus less likely to respond. Adverse events, I know, are particularly important to our patient populations. Many of them will think about and complain about fatigue or dry mouth. There's PSMA receptors in the salivary glands, so that's most bothersome to folks. But we also see the cytopenias, and I think Dr. Sommer's case has a particular difficult situation with cytopenias later on that we can talk through. But we do have dose reductions or delays for neutropenia in particular, and add in growth factors when we need. The phase 3 VISION trial was the global registrational trial for PSMA lutetium. This was patients who were randomized 2-to-1 in the refractory setting to either PSMA lutetium with abiraterone or enzalutamide, or the standard of care abiraterone or enzalutamide as supportive care. Primary endpoints on progression-free survival and overall survival. Many of these patients were highly refractory to prior therapies. All of them had received docetaxel, and about a third of them had received prior cabazitaxel. But as you see, progression-free survival was highly improved, hazard ratio of 0.4. I don't think we saw that in many of the registrational trials. And there's some controversy about whether Abi or Enza is the appropriate control cohort for these folks, but they were a very refractory patient population who had had prior chemotherapies. And then overall survival was improved, so patients were living longer. Median overall survival for these folks treated in the refractory setting was about 15 months for lutetium compared to standard of care alone. And side effects here are very similar to what we saw in therapy. Fatigue, dry mouth, and the cytopenias are the main ones. Particular grade 3 or higher anemia, thrombocytopenia, and leukopenia. In our clinics, we see that be quite rate limiting in some patients when we get into the later cycles of lutetium. So in thinking about sequencing therapies in metastatic castration-resistant prostate cancer, we still have somewhat limited lines of therapies, and so it's important to optimize that duration of treatment and also to test patients molecularly to find those patients who may benefit from PARPs and combinations, as well as the rare MSI-high patient who might benefit from pembrolizumab. Lutetium is coming to earlier lines of treatment. I did not show you data of PSMA-4, which is now available, pre-chemo lutetium. And I think it's important to think about creative sequencing for patients. This is a timeline of one of my patients I treated at Duke for many years. He lived with metastatic prostate cancer for 20 plus years, and ultimately had multiple trials that he was on at Duke. He was part of the VISION trial, and then even after the VISION trial, he was re-challenged with chemotherapy and also later on with PSMA lutetium. I told you I'd show you a patient with MSI-high disease. This is one of my patients who came to me with castration-resistant disease. I sent off his Guardant 360 circulating tumor DNA, and lo and behold, he had an MSI-high, as well as the highest tumor mutational burden I've ever seen, 109 mutations per megabase, so certainly qualified for pembrolizumab. With one cycle of pembrolizumab, his PSA dropped from 60s to 30s. With 2 cycles, it was in the single digits, and 3 cycles, he was undetectable. He ended up having some hypophysitis, headaches after cycle 3. We held him, and he was treatment-free for about 2.5 years without disease progression. Before this fall, his bone scan started showing some activity, so we re-challenged him with pembro, and he's doing quite well. In summary, a very aggressive disease can be treated. I think we can find those patient populations likely to benefit from these targeted therapies, and I really appreciate the opportunity to talk to you about prostate cancer. Thank you.
Thank you so much.